Hello, I'm Dr. Hafsa, and in this video, I'm going to walk you through some slides on bowel obstruction. So what is bowel obstruction? This term typically refers to a mechanical blockage of the bowel whereby a structural pathology physically blocks the passage of intestinal contents. Here I'd also like to mention that around 15% of the patients reporting to the hospital with acute abdomen are found to have bowel obstruction, which shows how important it is to identify and diagnose such patients timely. I'm going to classify our topic into four types. The first is mechanical or dynamic obstruction, in which the bowel is capable of contracting normally proximal to the site of obstruction. The second is non-mechanical or adynamic obstruction, in which the peristalsis may be absent due to neuromuscular failure, or it may be present but in a non-propulsive form. Let's see how the food moves through the intestine in a normal propulsive manner. Please excuse my drawing skills. Okay, so let's assume that this is a segment of the gut. I'm marking this as PS, the propulsive segment, RS, the receiving segment, and here inside this is the food bolus. First, there is an area of contraction behind the food bolus inside the propulsive segment. Here the circular muscles contract whereas the longitudinal muscles relax. This in turn pushes the food forward into the receiving segment. And this is how the food is moved through the intestine in a wave-like pattern. Thirdly, we can classify it on the basis of anatomy, so it can either be a small or a large bowel obstruction. And fourthly, we can classify it on the basis of nature of presentation, so it can either be acute or chronic. In acute cases, small bowel is usually involved and it is associated with sudden onset of severe colicky central abdominal pain with early vomiting and constipation. This can also be followed by abdominal distension. The chronic condition generally involves the large bowel with lower abdominal pain and absolute constipation. Now let's focus on the etiology or causes of bowel obstruction. They're also divided into dynamic and adynamic causes. To simplify them a bit more, I further subdivided them into three subtypes: the intraluminal, intramural, and extramural causes. The intraluminal causes arise from within the intestine, for example, fecal impaction, foreign body, fissures, and gallstones. Fissures are concretions of indigestible material like hair. The intramural causes arise from the bowel wall, for example, strictures or malignancies. Strictures can be seen in Crohn's disease. The extramural causes extend beyond the bowel wall, for example, adhesions and bands, hernias, volvulus, and intussusception. We're going to learn about them shortly. The adynamic causes include paralytic ileus, mesenteric vascular obstruction, and pseudo-obstruction. Here we can see how adhesions actually look like. So the adhesions can be in between the intestinal loops or between the intestine and the abdominal wall. Adhesions are basically bands of scar tissue that connect two internal body surfaces, and people who have had multiple surgeries in the past are more prone to develop adhesions. In intussusception, a part of the proximal bowel folds into the distal and adjacent segment of the bowel. As seen over here, the small intestine has folded inside the large intestine, whereas in volvulus, a loop of the intestine folds around itself and its mesentery. This generally occurs in elderly patients, patients with chronic constipation, and patients with neuropsychiatric disorders. Now I would like to draw your attention towards the pathophysiology of bowel obstruction. We can simplify it by looking at what happens proximal to the site of obstruction. Whenever intestinal obstruction occurs, the peristalsis increases to relieve the obstruction, but when this does not occur, the peristalsis ceases at some point. The fluid proximal to the obstruction accumulates and collects, in which the bacteria multiply. This results in a flaccid, paralyzed, and a dilated bowel due to the inflammation of the bowel wall. Whenever there is inflammation, we all know that macrophages accumulate and they release cytokines. To further aid this process, there is an increased release of nitric oxide and reactive oxygen species. Now we will see what happens at the site of bowel obstruction. As we discussed before, whenever the bowel wall is inflamed and dilated, the intraluminal pressure exceeds the bowel wall's venous pressure, which in turn impairs the venous return. Now when this happens, there is congestion and edema of the bowel, which further causes dilatation and ischemic injury, which in turn blocks the arterial supply and perfusion, eventually stopping the peristalsis and leading to necrosis. This in turn leads to gangrene, and bacterial toxins are released into the blood supply, and there is mucosal damage also because of the reactive oxygen species. This all leads to sepsis eventually. So far we've understood the basics of our topic. Now let's see how to diagnose a patient with such a condition. Starting off with a history, the onset might be acute or chronic. There might be a history of bleeding per rectum, constipation, weight loss, anorexia, or changes in bowel habits. There can also be a history of prior surgeries. On examination, we can find abdominal distension or a mass. This can also be associated with abdominal tenderness or guarding. On auscultation, we can find high-pitched or tinkling sounds. Moving on, let's have a look how the blood profile might look like. So if we get a complete blood count done, we will find raised white cell count, which indicates infection, raised hematocrit, which indicates hemoconcentration. Now this occurs due to the fact that the patient has reduced intake, there's decreased absorption from the gut, and the patient might also be vomiting. Now this triad leads to volume depletion and electrolyte imbalance, which is generally hyponatremia and hypokalemia. This in turn leads to raised serum urea and creatinine. This also occurs in cases of dehydration. If we get the LFTs done, we will find raised serum bilirubin and ALP, that is alkaline phosphatase. Serum amylase is a non-specific indicator, but it may be raised in some cases of small bowel obstruction. Serum lactate can be used as a good indicator for bowel ischemia. I would highly appreciate your feedback in the comments below. Please find the link to the second part of this video in the description box and subscribe for more videos. Hello, I'm Dr. Hafsa. In the previous video, we gained insight into the basics of bowel obstruction. Now, let's delve into the diagnostic imaging and management of it. To help us diagnose a case properly, we know how helpful diagnostic imaging is. So if we get an erect chest X-ray done, we can find free air under diaphragm as seen over here. Now here we can see multiple air fluid levels, which can be seen with the help of this line. This line separates the air from the fluid, and it is normal for a person to have air fluid levels in their intestines, but if they are more than 3, this is abnormal and it indicates intestinal obstruction. If we get a supine abdominal X-ray done, we can see dilatation of the bowel loops with or without air fluid levels. This is a normal AXR, whereas this is an abnormal AXR. This shows here an air fluid level and enlarged bowel. Basically, this intestinal loop over here is quite enlarged, and we can see multiple points where there's a lot of air inside the intestine. This indicates intestinal obstruction. Here we can clearly see the difference between a small and a large bowel obstruction on the basis of abdominal X-ray. In small bowel obstruction, the loop is dilated more than 3 cm but not more than 6 or 9 cm as it is in the case of large bowel obstruction. The location is generally central and we see valvular condiments. These are lines that extend from wall to wall and completely cross the bowel, as we can see over here. The large bowel obstruction is generally peripheral in location. It has haustral lines visible. These lines do not completely cross the bowel. As we can see over here, this is the site of obstruction. And there's the loop of sigmoid colon that is dilated. Now, if we get a CT scan done, it is performed with the help of oral or IV contrast. As we can see in the picture here, the loops of the bowel are dilated, and we can also see a transition point where the diameter of the bowel changes, indicating any kind of obstruction. Here we can see a non-linear boundary which indicates a small bowel obstruction, like we discussed about the air fluid levels in which there was a linear boundary. Coming on to the management of intestinal obstruction, we generally started off with a conservative treatment by keeping the patient nil per oral. We give him IV fluids according to the clinical and biochemical criteria. We catheterize the patient. We perform the nasogastric decompression with the help of a Ryle's or a Salm's tube and with 4-hourly aspiration. We check his temperature, pulse and respiratory rate 2-hourly. We perform the abdominal examination 8-hourly, and we give him broad spectrum antibiotics early to reduce the bacterial overgrowth. Some cases will settle by using this conservative regimen, others may require surgery. The surgery should be delayed until the resuscitation is complete unless there are signs of strangulation or evidence of a closed loop obstruction. The signs of strangulation include vomiting, absolute constipation, or the pain may become worse. The cases that show reasons for delay should be monitored for 72 hours in hope of spontaneous resolution. There is a famous phrase that the sun should not both rise and set in cases of unrelieved obstruction, which emphasizes that how important it is to treat the patient surgically in cases of unrelieved obstruction. So when do you know that the patient needs to be operated? In cases of failure of conservative management, when there is a tender and irreducible hernia, or in the cases of strangulation as we discussed before. The type of surgical procedure depends upon the cause of obstruction, and once the obstruction is relieved, the bowel is inspected for its viability, and if it's not viable, resection is required. Here we can see how a non-viable bowel looks like. This bowel does not have luster, it will not have peristalsis, there will be loss of pulsations in the mesentery, and the color of the bowel will change to a blackish brown color. I have briefly described the operative management of small bowel obstruction. In cases of obstructed hernia, the constricting agent is divided, but it should not be done in cases of hernias involving the foramen of Winslow and periduodenal fossas, as the major vessels run at the edge of the constricting ring. In cases of gallstones, the nephrotomy is done and bezoars are removed by open procedures. In cases of stercorates and worms, these are removed with the help of phlebotomy, and sometimes it may also be possible to knead the mass into the cecum. Adhesions are preferably treated conservatively, but in some cases adhesiolysis is required, which is done laparoscopically as shown over here. A laparoscopic shearer is used which coagulates and divides the adhesions. The bands are generally divided in intussusception. If the patient is a child, air or contrast enemas are given, whereas in adults, surgery is required. When the large bowel is obstructed, after full resuscitation, the abdomen is opened through a midline incision, and the distension of the cecum confirms that the large bowel is involved. When a removable lesion is found in the cecum, ascending colon, hepatic flexure, or proximal part of the transverse colon, an emergency right hemicolectomy is done. For obstructing lesions of the left colon or the rectosigmoid junction, an immediate resection is done. In cases of cecal volvulus, if it is found to be ischemic, resection is required, but if it is viable, it is reduced. Cecopexy is done, in which a part of the cecum is sutured to the ascending colon under the flap of parietal peritoneum. In sigmoid volvulus, a flatus tube is inserted with the help of a flexible or a rigid sigmoidoscope to deflate the cut. This is left in place for 24 hours and a repeat X-ray is done. Whereas in elderly patients with comorbs, the options are to resect or to do a two-point fixation with a combined endoscopic or percutaneous tube insertion. Lastly, let's see how to treat an adynamic obstruction. In cases of paralytic ileus, nasogastric decompression and restriction of oral intake is needed until the bowel sounds or the passage of flatus returns. Laparotomy is done if the bowel is inactive for more than 7 days. In cases of pseudo-obstruction, which is the dilatation of the bowel in absence of any anatomical obstruction, if it's a small bowel pseudo-obstruction, the underlying disorder is corrected with the help of metoclopramide or erythromycin. If it's a large intestinal pseudo-obstruction or Ogilvie syndrome, after confirming the diagnosis, an anticholinesterase inhibitor like neostigmine is given, but if it's unsuccessful, colostomy may be needed. I would highly appreciate your feedback in the comments below. Let me know if you want me to make more videos on topics of your choice. Thank you for watching. Please like and subscribe. Hello, I'm Dr. Hafsa, and in this video, I'll be educating you about traumatic brain injuries. Starting off with extradural or epidural hematoma, in which there is bleeding into the space between the dura mater and skull. The dura mater is the outermost layer, whereas the pia mater is the innermost layer. We can remember it as DAP, dura mater being the outermost, pia mater the innermost, and arachnoid in between them. This results due to acceleration and deceleration trauma or blow to the side of the head, specifically pterion, which results in the rupture of the middle meningeal artery, as shown over here. It can also result in the rupture of anterior ethmoidal arteries if trauma is to the frontal region. The patient presents with altered state of consciousness or a lucid state. This is a brief interval where there is regained or restored consciousness. The patient might have CSF leak from the nose, rhinorrhea, or from the ears, otorrhea. The patient might have signs of raised intracranial pressure, for example, nausea, vomiting, or he will have Cushing's reflex, which is a triad of hypertension, bradycardia, or an irregular breathing. Complications may arise if the extradural hematoma is not treated timely. Let's learn this with the help of a diagram. For instance, this is the tentorium, which is the fold of dura mater that separates the cerebellum from cerebrum. And if the complications arise above the tentorium, they compress the arteries leading to ischemic stroke, but if it's below the tentorium, they compress the brain leading to heart and respiratory arrest. To diagnose an epidural hematoma, we generally use a CT scan, which shows a biconvex, heterogeneous and high-density mass, which is generally bright in color, whereas on the MRI, on the T2 weightage image, we find a hypointense or a dark-colored blood clot. We can also find a swirl sign on the CT scan. This is basically an area of low attenuation within an hyperattenuating hematoma. For instance, this is the hematoma, and this inside is the area of low attenuation or low density, which is darker in color as compared to the rest of the hematoma. Coming on to the management, we use osmotic diuretics like mannitol to decrease the intracranial pressure, and we also go for anticoagulation reversal. But if this does not resolve the problem, craniotomy and hematoma evacuation is eventually needed. Subdural hematoma occurs when there is bleeding into the outermost meningeal layer, that is between the dura mater and the arachnoid mater. This occurs when there is bleeding from the damaged bridging veins in between the cortex and the venous sinuses. The initial injury may be minor and it is often forgotten. It occurs due to trauma, acceleration, deceleration, or group or countergroup injuries. The risk factors include old age, alcoholism, and anticoagulation. The patient may present with either loss or altered consciousness. There is sudden and severe headache with nausea and vomiting. There can be unequal pupils, difficulty in speech, and swallowing. If this is not treated timely, complications can develop, for example subdural hygroma, which is liquefaction of the granulation tissue which mostly occurs in chronic subdural hematoma. This in turn leads to raised protein which causes expansion of the mass due to water that is drawn by osmotic pressure. Now this leads to mass effect brain injuries. It can also lead to raised ICP, that is intracranial pressure, and progressive dementia. A subdural hematoma on a CT scan appears as a hyperdense, crescent-shaped mass that looks like a moon. Here we can also see shift of the midline, which shows mass effect. On MRI T2 weightage image, we can find a hypointense blood clot. Coming on to the management, we can prescribe diuretics which decrease the intracranial pressure. We give vitamin K, factor VIII inhibitor activity bypassing agent, and fresh frozen plasma. We also reverse the anticoagulation. We can go for a per hole drainage, craniotomy or a decompressive type of it, and blood vessel ligation if the diuretics and the above measures fail. Subarachnoid hemorrhage occurs when there is bleeding into the space between the pia mater and the arachnoid membrane, as shown over here. This occurs when there is rupture of the perianeurysms mostly. Perianeurysms are associated with multiple conditions like adult polycystic kidney disease, Ehlers-Danlos syndrome, and coarctation of aorta. It can also occur due to arteriovenous malformations, traumas, or tumors. The patient presents with worst headache of his life, or a thunderclap headache. He can also have altered consciousness, signs of meningeal irritation like neck pain and stiffness. There can also be positive Kernick sign and focal neurological signs, which involve posterior communicating artery, and abducens nerve. If this is not treated timely, complications can occur like rebleeding, which occurs mostly in patients with hypertension, anxiety, and seizures. The patient can also develop obstructive hydrocaph due to blood in the ventricles and vasospasm, leading to cerebral ischemia. CT scan of a patient with subarachnoid hemorrhage shows blood in the basal cisterns at the base of the brain, where the circle of Willis is located, as shown over here. The circle of Willis somewhat lies over here, and this star-shaped area shows that the blood has accumulated in the basal cisterns that are folds or compartments of subarachnoid space, which have a lot of CSF in them. The lumbar puncture is done after 12 hours, which gives time for xanthochromia to develop, which is yellow discoloration due to erythrocyte breakage. But if there is no xanthochromia and still there is high clinical suspicion that the patient has subarachnoid hemorrhage, a CTA or cerebral angiography is done. The management involves several steps. The patient is given antihypertensives, osmotic or loop diuretics, calcium channel blockers like nimodipine decrease the vasospasm, and seizures are treated. Endovascular coiling with aneurysm obliteration or craniotomy with aneurysm neck clipping or coiling is done if the above treatment is insufficient. Thank you for watching. Please subscribe and follow for more videos. Hello, I'm Dr. Hafsa. Today, our focus will be on grasping the fundamental concepts of genetic disorders, including their modes of inheritance. Before we go into the details of the modes of inheritance, I'd like you to have a solid understanding of these definitions. Chromosomes are self-replicating structures that contain cellular DNA that bears in its nucleotide sequence the linear array of genes. Let's understand this with the help of this diagram. This X-shaped structure right here is the chromosome. Inside this is the supercoiled DNA. This DNA is made up of these four bases, cytosine, guanine, adenine, and thymine, and this area right here is the functional part of the DNA or the part of the DNA that encodes for a specific protein. This is known as the gene. This gene is located in a specific area on the chromosome, and this area is known as the locus of that particular gene. To understand the concept of alleles, let's suppose that this is the allele for the hair color. If this is black and this over here is brown, so basically the alleles are alternative forms of gene found at the same locus as we discussed, the same area, but they're on different sister chromatids. And at the time of division, when this chromosome is divided and separated, the sister chromatids are pulled apart. So each allele is inherited separately from each parent. Now, what is a karyotype? A karyotype is the number and appearance of chromosomes in the nucleus. In human, there are 22 pairs of autosomes and one pair of sex chromosome. This pair decides whether the baby will be a girl or a boy. Autosomes are any chromosomes other than the sex chromosomes. Starting off with autosomal dominant inheritance, in which all offsprings of an affected person will have 50% chance of inheriting the mutation. Only one copy or allele of the autosomal gene is needed for the disease to manifest. Both male and female children will be affected and only the affected individuals can pass on the disease. Normally, it appears in every generation. Here, the father has one mutated or affected gene, and this results in 50% of his offsprings being affected, whereas the other 50 are unaffected. Let's learn it with another example. For instance, both parents are affected with the disease, and I'm marking it with XD. Their offsprings will be heterozygotes, homozygotes, and normal. Let's change the color so that it's easier for you to understand. Here, there is an interesting concept. This right here is the homozygote for the disease because she has two genes that are mutated, whereas these two offsprings will be heterozygotes because only one of their genes is mutated. This right here will be the normal offspring. And this leads us to a 75% probability of the offsprings being affected, whereas 25% will be normal. The risk remains the same for each pregnancy, and some examples include achondroplasia, adult polycystic kidney disease, HHT, von Willebrand disease, neurofibromatosis, and so on. In autosomal recessive inheritance, only homozygotes are affected. Both males and females are equally affected, and it may skip a generation, which means that an affected parent is not necessarily going to produce an affected offspring. In this case, both the parents are carriers, which means that they have one mutated gene and their offsprings will be 25% of them will be unaffected, 50% will be carriers, and 25% will be affected. Here's another example in which one parent is homozygous for the disease, whereas the other one is unaffected. Now, in this case, all of their children will be carriers. I'm changing the color. As we can see over here, all the offsprings have one mutated gene, which means that all of them are carriers. And for an autosomal recessive disorder to manifest, two mutated genes are needed. Here are some examples of relatively common diseases, and I have written them in this way for you to memorize them easily. A for albinism, B beta thalassemia, C cystic fibrosis, D deafness, E emphysema, and so on. Moving on, let's learn the X-linked dominant inheritance. We already know that females have two X chromosomes, whereas males have one X and one Y chromosome. So if a child has inherited the mutated X chromosome, even from one parent, they will manifest the disease. So a woman with the X-linked dominant disorder has a 50% chance of having an affected daughter or son with each pregnancy. As shown over here, the mother has only one affected or mutated gene, and this results in 50% of her children being affected, and the remaining 50% are healthy. So we learn that only one mutated gene is needed for the disease to manifest in the cases of X-linked dominant inheritance, whereas If the father has the disease, I'm marking it as XD, and if the mother is completely normal, let's learn how the offsprings will be. I'm changing the color. So in this, we learn that both the daughters will be affected by the condition, whereas the sons will be spared because the father passes on the Y chromosome to his sons. Some examples of X-linked dominant disorders are vitamin D resistant rickets, Alport syndrome, and Rett syndrome. In X-linked recessive inheritance, only males are affected because two mutated genes are needed for the disease to manifest. But in the cases of Turner syndrome, where there's only one X chromosome, 45X naught, this X chromosome, if this is mutated, the disease will manifest. In X-linked disorders, recessive disorders, male-to-male transmission is not seen because the male or the father only transmits the Y chromosome to his son. And as seen over here, the father is sick because he has only one chromosome, and that chromosome unfortunately is mutated, whereas the mother is a carrier because she has only one mutated X chromosome, but the other X chromosome is normal. This results in 25% of her daughters being carriers, whereas the other 25% will be sick, whereas the sons will be either sick or healthy. There's no carrier state in the sons. Let's learn it with another example. For instance, the father is sick or affected, whereas the mother is completely normal. Now, what will happen is, I'm changing the color again. This will result in all the daughters being carriers and all the males being healthy. And why? Because the daughters have only one mutated gene, whereas the sons are completely normal with no mutated gene. I hope this video was helpful. Please like and subscribe to my channel. Thank you for watching. Hello, I'm Dr. Hafsa. Today I will explain the basics of hypertension or raised blood pressure in a way that is easy to understand. Blood pressure is the pressure of the blood pushing against the walls of your arteries. If this is an artery, the blood inside the lumen of the artery or the vessel will exert pressure on the walls of the arteries. I'm marking it with arrows so that it's easier for you to understand the direction. And this is known as the blood pressure. So hypertension is basically the persistent elevation of the blood pressure above 140 over 90. Normal blood pressure is 120 over 80 or less than 120 over 80. So the systolic blood pressure measures the pressure in your arteries when the heart beats or contracts. This right here is the systolic blood pressure, whereas the diastolic blood pressure measures the pressure in your arteries when the heart relaxes. And this right here is the diastolic blood pressure. There's another hypertension known as the white coat hypertension. This generally occurs in hospital or office settings where a doctor wears a white coat, and due to anxiety or stress of being in that hospital setting, the blood pressure is raised. And we can rule this out by an ambulatory blood pressure monitoring that is done at home for 24 hours. Moving on to the etiology or causes of hypertension, it can either be primary, in which there is no identifiable cause, or secondary, in which the renal system, which basically regulates the blood pressure of the body, accounts for 80% of the cases of raised blood pressure. Some cases like glomerulonephritis, adult polycystic kidney disease, and renal artery stenosis can lead to raised blood pressure. Endocrine disorders like Cushing syndrome, Conn syndrome, pheochromocytoma, acromegaly can also contribute to a raised blood pressure. Others like pregnancy, coarctation of aorta, combined oral contraceptive pills, and steroids can also lead to raised blood pressure. We generally classify hypertension into three stages. The first is pre-hypertensive stage, in which the person is not labeled as hypertensive, but he is prone to develop it. The range for systolic blood pressure is 120 to 129, diastolic is below 80 mm of mercury. The stage 1 starts from 130 to 139 mm of mercury, and diastolic blood pressure is 80 to 89 mm of mercury. These two stages are managed by lifestyle modifications, whereas the stage 2, in which the blood pressure is 140 over 90, this stage is managed with pharmacotherapy or medicines. There is another stage, the hypertensive crisis, in which the blood pressure is above 180 over 20, and this can lead to organ damage or failure, which is also known as hypertensive emergency. So how does hypertension occur? Basically, it is an interplay of the genetic and the environmental factors. Whenever there is a defect in the renal sodium hemostasis, there is an inadequate sodium excretion, which means that the sodium is retained inside the body. Now, when this happens, the body resorbs more water from the kidneys, which results in increased plasma and extracellular fluid volume. This eventually leads to raised cardiac output, which is the amount of blood pumped by the heart per minute. When this is raised, it eventually leads to raised blood pressure or hypertension. The environmental factors like air or noise pollution, cold temperatures, and high altitudes can also lead to functional vasoconstriction or defects in the smooth muscle growth and structure. This leads to increased vascular reactivity and increased vascular wall thickness. When this happens, the total peripheral resistance or the systemic vascular resistance is raised. When the resistance increases, the pressure of the blood inside the artery's lumen also increases. Now, when this pressure is increased, as we discussed before, this leads to hypertension. There's another system known as the renin, angiotensin, aldosterone system, or the RAS system. This system basically regulates the blood pressure, but this occurs in the kidneys. And this system plays a very pivotal role in regulating the blood pressure. I will make a separate video on this soon. Most of the times a person knows when their blood pressure is raised. There are a few clinical features associated with it, for example, dizziness, headache, heart palpitations, nosebleeds, shortness of breath, anger, visual problems, fatigue, insomnia, but sometimes it acts as a silent killer and a person may not know how high their blood pressure is, and that is a very dangerous situation. A diagnosis of elevated blood pressure is based on the average of two or more blood pressure readings. Generally, we ask the patients to take blood pressure readings at home for 7 days. We discard the reading taken on the first day and take an average of the rest of the readings. The measurement should be taken on separate occasions in the same way. The first time the blood pressure is checked, it should be measured in both arms to determine if there's any difference, and the arm with the higher reading should be used. A longer blood pressure monitoring test can be done to check the blood pressure at regular times over 6 or 24 hours. This is done when the diagnosis is unclear. This is called as ambulatory blood pressure monitoring. We discussed about this when we were talking about the white coat hypertension. But if the practitioner knows that you already have hypertension, there are a few tests that need to be done, like complete blood count, lipid profile, blood sugar test, kidney function and thyroid function tests, and ECG. This rules out if there's any secondary cause of hypertension. We discussed about these in the slides before. There are a few risk factors that contribute to the development of hypertension. For example, age, race. Afro-Caribbeans are more likely to develop it as compared to the Caucasians, and they do so at an earlier age. If you have a family history of hypertension, you are more likely to develop it. Being obese or overweight is a very strong risk factor. Lack of exercise, tobacco use, or smoking. Now, smoking plays a pivotal role in the development of hypertension. Very, very important. Too much salt or sodium in your diet urges the body to retain more fluid, and this in turn increases the blood pressure. Low potassium levels can also lead to raised blood pressure because potassium maintains the salt homeostasis in the body. Drinking too much alcohol, stress, and chronic conditions like kidney disease, diabetes, sleep apnea are some of the common conditions that can also lead to raised blood pressure. I will make a separate video on the relationship of diabetes and hypertension. Pregnancy also sometimes increases the blood pressure. Moving on to the management. If the patient is in the pre-hypertensive or stage 1 phase, we generally offer them lifestyle modification, which includes weight reduction, sodium cut down, DASH diet, reduced smoking and alcohol, and stress management. This itself is very important and it helps them control their blood pressure, and some patients might not need pharmacotherapy, but pharmacotherapy is needed for stage 2 patients where the blood pressure is equal to or more than 140/90. We generally start off with ACE inhibitors if the patient is less than 55 years of age. But if the patient is more than 55 years or he or she is an Afro-Caribbean, we start them off with calcium channel blockers. ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2, and it prevents the vasoconstriction. Some examples are captopril and ramipril. Calcium channel blockers block the movement of extracellular calcium into the cell, causing vasodilation and decreased heart rate. Some examples are verapamil and amlodipine. Diuretics inhibit the sodium resorption in the distal convoluted tubule, ascending limb, and loop of Henle. Basically, they can either be loop diuretics, thiazide diuretics, or any kind of diuretics. For example, furosemide, chlorothiazide. Beta blockers reduce the workload of the heart to beat slowly and with less force. Some examples are propranolol and atenolol. Vasodilators like nitroglycerin or sodium nitroprusside can be given, and they act on the muscles of the artery, preventing them from narrowing. If you found this video helpful, please give it a thumbs up and consider subscribing for more content like this. Hello, I'm Dr. Hafsa. Today, my focus will be on providing a comprehensive overview of diabetes. Diabetes is a chronic and long-lasting condition that happens when your blood sugar or glucose is too high. It happens when your pancreas doesn't make enough or any insulin at all, or when the body isn't responding to the effects of insulin properly. Let's discuss how. There are two types of diabetes, but before that there is a stage known as the pre-diabetic stage, in which the blood glucose levels are higher than normal but not high enough to be officially diagnosed with type 2 diabetes. What happens is whenever you intake something, the glucose is released into the blood, and to counterbalance that, a certain amount of insulin is released. And this is the normal process. But if you take excess amount of glucose, excess amount of insulin is needed to counterbalance that. When this keeps on happening and the difference between the insulin released to the glucose that is released into the bloodstream, when this difference keeps on increasing, there comes a time when the glucose cannot be counterbalanced, and that is the stage known as the type 2 diabetic stage. In type 1 diabetes, there is an autoimmune process in which the body's immune cells or the immune system attacks and destroys the insulin producing cells of the pancreas. The beta cells in the pancreas produce insulin, and they're attacked by the T cells of the body. This is a type 4 hypersensitivity reaction. When this happens, there's no insulin produced inside the body, and insulin is needed for the glucose to enter the cells. For instance, this is the cell, and the door of this cell is right here. The key to the door is the insulin. But if there's no insulin, there will be no key to the door, and the glucose is unable to go inside the cell. When this happens, the glucose keeps on moving inside the bloodstream, and this raises the amount of glucose, hence diabetes. Whereas in type 2, the body doesn't make enough insulin, or the body's cells do not respond normally to the insulin, which is known as the insulin resistance. In this, the cell of the body has certain membrane transporters of glucose. These membrane transporters do not attach to the cell wall, and due to which, or if they do, they are not functional. But when this happens, the glucose is unable to attach itself and get inside the cell. So basically, there's an insulin resistance, or this is known as the insulin resistance. There are several factors and conditions which contribute to varying degrees of insulin resistance. For example, obesity, lack of exercise, hypertension, and sometimes genetics. Autoimmune diseases like type 1 diabetes, as we discussed before, and latent autoimmune diabetes of adults. Basically, this is sometimes referred as type 1.5 because it has features of both type 1 and type 2 diabetes. So it can have autoimmune processes in it and insulin resistance both. Hormonal imbalances, for example, during pregnancy, the placenta releases the hormone that causes insulin resistance, and this leads to gestational diabetes. Pancreatic damage, which occurs as a result of a physical insult, which is due to any kind of surgery or injury, can impact the ability of pancreas to produce insulin. This is also known as type 3C diabetes. Genetic mutations like HNF4 alpha can lead to maturity onset diabetes of young and neonatal diabetes. Long-term use of certain medications like the medications of HIV/AIDS and corticosteroids can also lead to diabetes. Thankfully, there are a few symptoms that help us diagnose a patient with diabetes. For example, the patient is always tired because the glucose is unable to enter the cell, due to which no energy is generated. And when no energy is generated, the body is always fatigued and the person always feels tired. There's frequent urination. This happens because when there's a lot of glucose in the bloodstream, there's a signal to the kidney to filter this glucose out of the body. When this happens, a lot of water goes out with this, and due to this, a lot of urination occurs. When this happens, the person feels thirsty all the time. Other than this, the person can have a blurry vision because whenever there is any change in the fluid levels of the body, the lens of the eye swells up. When this lens swells up, the vision becomes blurry. Other symptoms like numbness or tingling in hands or feet can occur due to neuropathy, and as the vessels to the organs get damaged over time, it can lead to sexual dysfunctions like erectile dysfunction and loss of libido and many other things. And because the body is unable to produce energy, the person always feels hungry because there is an energy debt in the body. To diagnose diabetes, we generally use three tests. The first one is fasting blood glucose, in which you don't eat or drink anything except water for at least 8 hours, preferably 12 hours, as food can greatly affect the blood sugar levels, and this allows the provider to see the baseline blood sugar levels. In a normal person, the blood sugar levels should be less than 100. In a pre-diabetic person, these levels will be between 100 to 125. But if they are more than 126, this means that you are diabetic. A random blood glucose means that you can get this test done anytime, regardless of the fact that you have eaten or not, and a value of more than 200 indicates diabetes. An HbA1c or glycated hemoglobin test provides an average blood glucose level over the past 2 to 3 months, and in clinical practice, this test is generally used to diagnose a patient with diabetes. A normal patient will have the value below 5.7% or 39 millimole per mole, whereas the pre-diabetic stage starts from 5.7 to 6.4, and the diabetic stage starts from more than 6.5 or 6.5, that is 48 millimole per mole. Managing diabetes can be challenging, but the first and the foremost thing is the diet. The diet should include low carbs. It should not have refined grains like white rice or bread. It can include fruits, vegetables, whole grains, and low fat milk. Other than this, exercise also plays a pivotal role in increasing the insulin sensitivity. And type 2 diabetic patients should have a regular regimen of exercise. You can monitor your blood glucose levels with a glucometer at home, and this gives the healthcare provider uh, the best blood sugar range for you. This decides whether you need oral diabetic medications or insulin. Oral diabetic medications help manage the blood sugar levels in people who have diabetes but still produce some amount of insulin, like type 2 diabetics and diabetics, sorry. People with gestational diabetes also need oral medications like metformin, which is the most common medicine, and generally we start off the patients with metformin. Other than this, sulfonylureas, thiazolidinediones, and GLP-1 agonists can also be given. I can make a separate video on these medicines, how and when they're given. People with type 1 diabetes or insulin dependent diabetes have to have insulin. There's no other option for them. But some people with type 2 diabetes also require insulin. And there are several different types of synthetic insulin, and they start to work at different speeds. They last in your body at different for different lengths of time. For example, the injectable insulin that can be rapid, short acting, and long acting. Diabetes comes with many complications. For example, brain stroke, cardiovascular diseases, diabetic nephropathy, diabetic neuropathy, and diabetic retinopathy. All of these occur when there's a damage to the blood vessels and the nerves. The small blood vessels supplying the nerves get damaged, due to which the nerves eventually are deprived of the oxygen supply and the blood supply. Along with the diabetic retinopathy, eyes can develop cataract and glaucoma in patients with diabetes. Periodontal diseases can occur when there's increased amount of glucose in the saliva, which helps the bad bacteria to grow. This with the food forms a sticky layer over the teeth, leading to plaque formation. This plaque leads to tooth decay, bad breath, and cavities. Foot damage can also occur when their nerves are damaged. There's a decreased sensation. When there's a decreased sensation in the foot, small injuries go unnoticed, and when this happens, the injury becomes bigger and bigger. And as we know that the blood supply is also damaged, is also unable to provide enough oxygen for the injury to heal, this eventually leads to gangrene and amputation is needed. I hope this video was easy to understand. If you have any questions, please feel free to ask them in the comments below. Like and subscribe to my channel. Thank you for watching.